It is really a true honor to be right now here and talk to you about pediatric trauma. These are just very high level approaches. If there are any more specific issues that you would like to discuss, please feel free to interrupt me at any point, or maybe just put in the chat your questions. So with that in mind, we're going to start with the resuscitation in pediatric after trauma and burn injury. Next slide, please. So our main objectives in here is to describe some of the anatomic, physiological, and treatment strategies for pediatric patients who have suffered trauma, to recognize and apply the ABCD approach, and we're going to go through some of the different acronyms that exist, to define the management of an injured or burned pediatric patient after the initial resuscitation, and to recognize the importance of having the family and our social support involved in caring for critically ill children. Next slide, Claudia, please. So let's start with some of the anatomical, physiological, and treatment strategies. And with that, we're going to go with our first slide. All these slides are actually available if you are interested in getting them separately, just by using Wi-Fi and Google them. This is the basic pediatric BLS for lay rescuers, something that we actually teach to our different communities in trying to provide some care for children who have suffered an acute injury. So you can see step 1 and step 2 are very common. For step 3, I thought it was important to highlight the frequency of the compressions related to the breaths. And that depends if we have an infant or a child. And the main difference is the age range. So we call the infants kids less than 2 months of age. And you can use your palm to do CPR when it's a child. And when it's an infant, we can use actually 2 fingers to provide the same kind of support during chest compressions. And next slide, please. In pediatric basic life support, and this is for the pediatric group, the most important thing is to define if we have 1 or 2 rescuers. If you follow this algorithm, and I don't think you can see my pointer, but if we go to the first one, on the very top, the orange one, we check for responsiveness and ask for help. And the most important thing is getting into that pink figure where we have to define if the patient is breathing or not breathing, or if the patient is having some gasping respiration. So if the patient is actually breathing on its own, we can keep monitoring the patient. However, if the patient is not having a normal breathing or has stopped breathing, then we need to provide the breathing rescue. So 1 breath every 2 or 3 seconds. So you can count 1001, 1002, or you can actually follow your watch and see how often you need to do it. That actually requires also to assess, which is the next step, and define if you have a heart rate in place. If the heart rate is less than 60 per minute, and this is for children, this is not the same as the adult population, less than 60 requires CPR. So you need to start chest compressions. If the patient's heart rate is greater than 60, then you can continue supporting the breathing pattern, or just continue monitoring if they're breathing. So as you move on, you try to activate actually an emergency response to someone that can help you. You need to assess for a sudden collapse. So we have that commonly occurring in our young athletes where they're practicing their sports and sometimes they just collapse. Usually it's associated with some kind of genetic problems with the cardiac receptors. So we start CPR, and that depends if we have 1 or 2 rescuers. Usually it's just 1 rescuer who starts, and they do cycles of 30 compressions and 2 breaths. And that continues until a second person can come and help out. So once you have 2 rescuers, your compressions go to 15 compressions and 2 breaths. The most important thing is effectiveness in the compressions. If the compressions are not completely provided, supported, then we are going to have a lot more cases of brain or neurological sequelae in those patients. So the way we want to remind people is good chest compression is good neuron output. And then we continue to check the rhythm. And the important thing when you have any kind of rhythm or you're assessing for a cardiac rhythm is to define if you have a chokeable or a non-chokeable rhythm. So if we go to the next slide, please. In here, you can actually, well, let me go to my slide. So in this particular slide, you start looking either if you have ventricular fibrillation or ventricular tachycardia versus complete asystole. So when you have ventricular fibrillation or tachycardia, we all know that those are chokeable rhythms, and we normally use 2 to 4 joules per kilo. So we do the first choke, and we don't wait to see what kind of response. We continue doing CPR for another 2 minutes until we check again. Once we check, we will find out if, in fact, we have a return of spontaneous circulation, or if not, we're going to need to assess if the patient still has a chokeable rhythm or a non-chokeable rhythm. If the patient is completely asystolic, as on the line in the middle, then we need to start using epinephrine. And the epinephrine is provided every 3 to 5 minutes and reassess. And we continue with CPR until we define exactly what's going to be the final outcome for our patient. Our pediatric patients with good CPR tend to have good neurological outcomes, even if we stretch that CPR period for 30 minutes. So we had good outcomes. But the most important thing is to provide enough circulation to actually have good perfusion to the brain. When we're assessing a patient who has either ventricular fibrillation, ventricular tachycardia, or asystole, we need to always start looking for the reversible causes. And that's actually in the box at the very bottom that talks about hypovolemia, hypoxia, the fact that the patient might be acidotic, hypoglycemia, which is something that we should check in all our children, particularly less than 5 years of age, and specifically important in kids less than a year of age. Hypothermia, hypo or hyperkalemia, and then we go through the 5 T's, which is the tension pneumothorax, tamponade, toxins, that thrombosis, either coronary or pulmonary. So just to emphasize how often we see hypoglycemia in children, unlike we adults where we have enough glycogen storage in our liver, children do not have that. And that's the reason why they need to eat so often, every 2 or 3 hours when they are babies. It's just because there's not enough glycogen in their liver stored to be used for long periods of lack of nutrient. So just keep an eye on the glucose. Any kid that's less than a year of age needs to have frequent glucose checks, particularly if they're not getting glucose. And when you start an IV, it's very important that all the solutions have some component of glucose when you do maintenance IV fluids. Next slide, please. So in some of our algorithms from the American Heart Association, and let me get to that. I think it's basically the same slide that you guys just saw, but now it's been translated, so I'm not going to repeat all the details. If there are any questions about this slide, please put them on the chat or just interrupt me. The next thing that I wanted to bring up to you guys is the American Heart Association has created this post-cardiac arrest care. It is very common that we go through the acute resuscitation, which is the first 15 to 30 minutes. And then people who are not familiar with children really don't know what to do with them. So in this one, there are several aspects that are included. We'll start with oxygenation and ventilation. So ideally, we want to maintain an oxygenation that's greater than 90% for sure. In here, they highlighted 94 to 99%. And if possible, if we have the opportunity to measure capnometry, the end-tidal CO2 detector, then it would be ideal to maintain that and prevent severe hypercapnia, which can actually cause more damage to the brain, or hypocapnia, which also can have repercussions in the brain. As far as hemodynamic monitoring, we need to have good hemodynamic goals based on the age group, so a systolic pressure that actually provides perfusion not only to the brain, but to the abdominal organs. And those need to be reassessed on a daily basis. We need to have, if possible, cardiac telemetry, frequent blood pressures, and if there's a chance to have an arterial line, an arterial blood pressure measurement. Lactates give us an idea of how well the perfusion is occurring, followed with urine output, where our goal is around 1 cc per kilo per hour. And then, if possible, a venous oxygen saturation. That will actually guide us in some of our management. As far as temperature, it is not a common practice to induce hypothermia in all our patients after cardiac arrest. It is mostly commonly done in the neonatal group in children less than 30 days of age, where we try to maintain hypothermia in the 35, 36 range, for about 24 to 48 hours, no more than 72 hours. Ideally, the most damaging temperature for our brain is anything that's greater than 36.5. So we try to avoid hypothermia by any means possible. So the temperature between 32 and 34 is not commonly done because it has been associated both with predisposition to infection because the immune system is compromised, as well as developing other types of infections, not only respiratory infections, but if there is a trauma patient, we tend to have also complications from that standpoint. We try to prevent shivering in all our patients, particularly when they're going into the hypothermia mode, if that's the chosen path by the clinician. And what we do in those patients is, if they are intubated and we're trying to induce hypothermia, we just used intermittent chemical paralysis with neuromuscular blockers. And then we monitor the blood pressure and avoid hypotension. So hyperkalemia and hypotension are quite commonly seen. Hypokalemia and hypotension are commonly seen during the rewarming phase of all these patients. As far as neuroimaging, the most important thing is to avoid seizures. And it's important that we, the clinicians, think about a seizure activity, particularly in a patient that seems to be obtunded and is not getting any kind of sedatives. Ideally, we would like to have continuous EEG monitoring if possible, and be very aggressive in treating seizures. As far as electrolytes and glucose, always keep an eye on the hypoglycemia and make sure that your patient is getting enough glucose and maintain electrolytes within normal levels. As far as sedatives and anxiolysis, we tend to do quite often use of alpha-2 agonists like dexmedetomidine in our patients, particularly when they require non-invasive ventilation. And as far as prognosis, it is always important to consider that all these patients need a multidisciplinary approach to cover not just one organ, but the whole system. And the whole system, a holistic approach also include having the family available for them to provide support. we need to continuously assess this patient and not think that one assessment is enough for a day. They're continuously changing, and children heal very fast, but they also can get sick very fast as well. Consider EEG and neuroimaging when it's possible. On the little square on the right, where you have red, green, and blue, that's the Richmond Agitation Scale that is actually quite available in the internet, so that you can assess sedation in those little kids who remain intubated and you need to maintain them sedated. We normally try a goal of +1 to -2, and we avoid deep sedation, as we're going to be discussing a little bit more further out. Next slide, please. Just a comment about our little NICU babies. I just wanted to make sure that we briefly go through this, because when children are born, these little babies lose their temperature quite often. So the most important thing is protect them and put a little cap on their head so that they don't lose temperature often. This algorithm just goes into what you need to do if that little baby starts having some issues breathing, as well as having a heart rate below 60. So just remember, stimulus and drying them and cleaning the secretions from the mouth and the nose is important to start them to have spontaneous breathing. If that doesn't occur, some stimulation might be appropriate. If the heart rate gets to greater than 100, this is a child that's going to start breathing on its own. But if it starts having some issues with breathing, then we're going to need to actually start considering non-invasive ventilation and oxygen supply. The important thing is to measure the heart rate at the umbilical level. So you touch the umbilical artery and try to define what's the rate. And if it's less than 60, to start compressions. Usually it's a respiratory cause that's causing the bradycardia. So once you address the breathing patterns, the heart rate actually peaks nicely. Next slide, please. So in this particular objective section, we're going to talk about the different acronyms and how we approach the pediatric trauma. In general, we talk about the ABCD approach. So if you go to the next slide, please. The two most important things, and this again is information available from the Children's Hospital of Philadelphia. They have very nice algorithm. We classified our traumas in trauma level 1 or level 2. So the level 1, we call them the red level. That means these are very sick children with extensive trauma or severe trauma injuries. And we have a system where ideally you communicate before the patient arrives so that the team is ready to receive this patient. Or sometimes they just arrive in a normal vehicle. So we need to prepare for that. We have a very specific system of transferring patients to a very high level locations. Number one, if they have burns, and particularly in this case, when the burn is greater than 15%, we send them to a burn center. Or if greater than 5% total body surface area with full thickness. Also electrical or chemical burns, and burns that will require grafting. When they're associated with vascular injuries, we transfer patients who are 15 years of age and older to another center. And here at Mayo, we have the adult hospital, which our trauma unit takes care of all our 15-year-olds and older patients. And then when you have severe pelvic fractures, those actually need to be addressed at a different level as well. Next slide, please. So when we talk about the acronyms, guys, there are several acronyms, and sometimes this is confusing for different people. So in the general medical population, we talk about the A, B, C, D, E, F. When you talk with the EMS group, which are the paramedics and medics who transport these patients, they actually talk about the X, A, B, C, D, E, F. And then when you look at the military medic training, they actually talk about march and pause. So the march in the handbook front is provided to you. I'll give you a QR later on so that you can access it if needed. It starts by just addressing massive hemorrhage. So that's the number one thing in any kind of adult or pediatric trauma, addressing hemorrhage, because that's how your patients will die. The same thing with the XABCD, which is used by the transport teams. The X stands for exsanguination. So we need to avoid severe hemorrhagic shock in this patient, and that's going to be the priority even before you get into the next assessment, which include airway, respirations, circulation. In military, head injury and hypothermia are actually quite important to address. And the one thing that is useful not only for the military, but also for any kind of trauma related to pediatrics is the pause algorithm. Make sure that we address pain. All these children tend to have several degrees of pain on top of their anxiety. So that needs to be addressed. Antibiotics, talking about the wounds, and the splinting, which is the follow-up care that they need. Next slide, please. Are you able to move it? There you go. So in this particular slide, we had, I actually had another presentation that had the QR for that will give you, and hopefully, Claudia, you'll be able to change that slide for this one. And this just highlights the significance of those two acronyms, MARCH and PAUSE. So again, pain, antibiotic, wounds, and splinting are an important point to address. Next slide, please. In this tactical textbook that QR guides you through, they actually go on to with all these 7 different algorithms, and I'm not going to go in detail through all of them. Just to say that on the first one, after you have secured the location of the patient, the first responders actually go with massive hemorrhage, and they're going to try to control the hemorrhage. If it's an extremity, ideally they can use a tourniquet, and the recommendation is high and tight. If no, then they continue with what they're doing. If it's a life-threatening bleeding, those that are considered life-threatening are arterial bleeds, spurting blood, complete or partial amputation, and the blood soaking, in this case uniform, but of course clothing in our patient. The second box in the middle continues to address the massive hemorrhage. And the massive hemorrhage actually includes if it's the limb, if it's a junctional hemorrhage, or an abdominal or pelvic hemorrhage. So as far as the limb, that's when we can use the tourniquet. As far as the junctional hemorrhage, that includes the groins and the axillaries. And then if it's an untreated abdominal or pelvic hemorrhage, you try to avoid a lot of movement and try to pack the abdomen or the pelvis if possible. As we move on from controlling hemorrhage to the airway, we need to find out if the airway is obstructed or not. If it is obstructed, then the question is, do we need to be more aggressive and do a surgical approach? And if not, I mean, the most important thing, being careful with the neck position is try to control the airway, maybe insert a nasopharyngeal airway, try to ventilate if there's the equipment available, If the patient is unconscious, try to recover a position that's going to be easy for the patient to breathe. If the patient is conscious, then that's going to be a lot easier to maintain airway. And then you move on to the third box in here, which is the respirations and the circulation. So as far as respiration, the important point to define if there is any kind of thorax, a thoracic injury. If there is so, then that needs to be addressed. The things to consider are actually pneumothorax, which will require some addressing immediately, putting the needle, doing a decompression with the needle, considering a chest. If it's an open wound, then that needs to be addressed, putting the 3-edge plastic coverage. And then you move on to circulation. And ideally, you will have some resources available. So isotonic fluid is the number one. Tranexamic acid is recommended in the military. We don't use that commonly in our pediatric trauma patients. And ideally, intraosseous or intravenous. For the adult military, and I know Dr. Niven probably can mention a little bit more about the sternal intraosseous that's used in adult. We don't do that in our pediatric populations. We try to use the extremities or the humerus to do intraosseous. And then we start the fluid resuscitation depending on the amount of bleeding that it's present. Next slide, please. So in this particular one, we just talk about the circulation in more detail and the fact that if available and the patient is bleeding, we need to do the 1-1-1 massive transfusion protocol where we try to use packed red blood cells, plasma, and platelets. On the middle, then we start addressing the H, which is the head injury or hypothermia, in the acronym of MARCH. And the most important thing is try to maintain temperature for this patient and provide medications that can support them. This is when pause becomes important, and we need to start thinking about antibiotic coverage and splinting any kind of fractures the patient might have. And the pain management is actually quite important. So it's going to be either oral or IV or IM, depending on what is available and how severe it is. And of note is the use of ketamine is not uncommon in patients with moderate pain until they develop nystagmus. And as far as antibiotics, I think that's locally related. So it depends on what is available both orally or intravenous to provide that kind of treatment to your patients. And then, of course, wounds, particularly if there's a burn injury associated to the initial trauma, that's going to need to have a little bit more detailed care than just some other type of open wound. The wound clearly will need a lot more support than just an abrasion. The splinting, the monitoring, and the documentation become important. And then next slide, please. At the end, it's going to be the MIS report, right? The report that we provide to those who are going to be taking care of the patient, where we actually describe what was the mechanism of injury, the type of injuries the patient has, what symptoms they presented with, and what kind of treatment we provided. And in that box in front of you, you actually go through the massive hemorrhage and what was done, and what kind of interventions were done and how we were monitoring them. How did you protect the airway and to monitor the casualty? And if the patient required endotracheal intubation or not. Find out if oxygen with a low source of oxygen was enough to maintain good pulse oximetry, or if the patient was actually completely unconscious or in shock. and required a different approach. And then the head injury and hypothermia. This is the most important thing because we all want good neurological outcomes, right? So if there's impending herniation and we're concerned about the type of head injury, that's when we actually go to the hypertonic saline, elevating the head and hyperventilate until we can provide a higher level of care. And then if that is not a problem, we need to continue to assess that patient, particularly with level of alertness and the pupillary changes. If the patient has hypothermia, remember severe hypothermia, anything less than 34 degrees centigrade will actually also cause coagulopathy. So if you have a bleeding patient, hypothermia is not the right approach for that particular patient, and we need to make sure that we maintain a normal temperature. Next slide, please. So as we move on, this is the next two slides are actually based on some of the common findings that we have in the massive hemorrhage, which is in the very top, and you guys are very well familiar with it. And then the A, B, C, D, E, as we move on. So what do you do in your exam to assess your airway? So if the patient is looking around, crying, if there's hoarseness, if the breathing, when you auscultate, if you have bilateral breath sounds, jugular distension, if possible, get a saturation or end-tidal VO2 assessment. And then circulation, inspect and palpate central pulses, peripheral pulses. As far as disability, determine your Glasgow Coma Scale. Always check the pupillary size and the glucose. Never forget to check for the glucose in these patients. As far as what kind of interventions you can have, the C-spine will get immobilized. The breath sounds you assess and make sure the trachea is midline and they're bilateral and equal. Always check capillary refill in pediatric patients. It's a very good sign of good perfusion in that patient, as well as the level of alertness. If a patient is crying, the cerebral perfusion pressure is appropriate. And try to maintain normothermia. So then the findings are associated with what you can actually encounter. And then the life-threatening issues are the most important part, at least for our assessment, that you're going to try to avoid. So a difficult airway or a critical airway, right, that can kill your patient. Attention pneumothorax that goes undiagnosed. As far as hemorrhagic shock, a massive hemothorax, cardiac tamponade, blunt trauma, penetrating injury, or a pelvic fracture. As far as disability, severe traumatic brain injury, intracranial injury, or spinal shock. And then hypothermia, never forget toxins, right? Toxins are always available, and we need to think about those. So the next slide, please. So this is the translation for you guys, and hopefully that's going to be useful. And then the next slide, please. And then that was the primary survey. And the secondary survey, which is the second thing that we do, that tends to be done either in radiology in the emergency room where the patient gets assessed. We go through the medical history and we use the AMPLE acronym. And then we assess each and every system, head, ENT, maxillofacial, and then all the different symptoms that you can actually find, and what is it that you're looking for, which is in the last column. So step-off fractures, mid-face instability, unequal pupils, hyphemas, periorbital contusions, hemotympanous, CSF drainage, trismus. And in children between the ages of 5 and 12, we can have loose teeth that can become a problem, particularly if we have to manipulate the airway. As far as the C-spine and the neck, we always need to make sure that we have a trachea that is midlined, that the C-spine is controlled. And when we check for, in our secondary survey for C-spine tenderness, that's going to be a big red flag in what needs to be done to maintain neurological good neurological outcome. And also we look for distended necks and pulsating hematomas. As far as the chest, we're looking for abrasions, changes in our breath sounds, abnormal movement in the chest. For the abdomen, rigidity and distension are the very important one. If the patient is conscious, if there is any tenderness, we need to make sure there's no bleeding. And then one thing that's important is the pelvis, peritoneum, and rectum. Particularly an unstable pelvis can kill a patient if there's a hemorrhage, because it's actually an occult bleeding that can continue the patient in hemorrhagic shock. So we look for tenderness, abrasions, or blood. And then extremities, you all know deformities, the absence of pulses, capillary refill, and then the altered mental status. So with that, I think we have covered some of the initial things that need to be addressed. Next slide, please. And then we move into the disposition and the continued care for our patients. And that's the primary and the secondary surveys. So remember, primary survey, usually it's done either in the field or in the local emergency room. And you go through the X, A, B, C, D, E, or the MARCH, whichever acronym you want to use. The secondary survey usually occurs in the emergency room, radiology, and that's the injury recognition and treatment. And then you go through that tertiary survey that normally occurs in an ICU setting. It's where you identified missed injuries, like a small fracture in the wrist that was not obvious on the first assessment. Next slide, please. So now let's go a little bit to the management of an injured or burned pediatric patient after you have resuscitated the patient. Next slide, please. So important here is we actually need to maintain clear upper airway and maintain cervical stability until we can clear the cervical spine. We need to have a definite airway, either with an oropharyngeal airway or with an endotracheal tube it's needed. In some extreme cases, we have a cricothyrotomy that will need to be transformed to a tracheostomy. If the patient does not require an aggressive airway management, we can actually think about using non-rebreathing masks or just start with a valve mask ventilation until we know if the patient will require an endotracheal tube or if we can maintain it with non-invasive ventilation. The most important thing for all these patients is in the continuous assessment is to look for life threat conditions that might actually be missed in the first or in the primary survey. Next slide, please. So what are those common life threats that we can miss? Tension pneumothorax, not uncommonly, that will require the needle decompression in the chest tube. An open pneumothorax, so that's when we actually can cover with a three-sided occlusive dressing, and then we place the chest tube. But the massive hemothorax, where volume resuscitation and chest tube ideally will control it, and if not, it's going to require surgical approaches. Next slide, please. So what are some of the important things to do? If there's a bleeding, we need to stop the bleeding, right? On the field, direct pressure, tourniquet, pelvic binders. And then if the bleeding continues and there's a difference in how we classify adult and pediatric patients, then we need to decide if the patient is hemodynamically unstable, that patient needs to go for surgery. If the patient is hemodynamically stable, then you have more time to assess if the patient will require surgery. Never forget volume resuscitation. We start with our volume resuscitation, which is an isotonic solution, or we can do the 1-1-1 massive transfusion protocol. But any pediatric patient, particularly less than 5 years of age, will require maintenance fluids that need to contain glucose. Then we monitor the urine output. Ideally, we have a urinary catheter, and you want to maintain a urinary output that's between 0.5 to 1 cc per kilo per hour. Ideally, If you're in a place where you can use central lines, you will use a central line, but now they're rarely needed for resuscitation. They might be needed later on for continuous management, particularly if you're not able to use the enteral route. And then laboratory values, that's something that needs to be addressed. And never forget to follow metabolic acidosis and lactase so that you're aware that your perfusion is appropriate for that patient. The next slide, please. So the etiologies for shock and trauma, we talked about the hemorrhagic ones, which includes all the different areas. But think about the pelvis and the thighs. A child can die of a hemorrhage in one of the thighs of hemorrhagic shock. And then if you have a patient in shock and it's non-hemorrhagic in origin, we need to think about obstructive, neurogenic, and cardiogenic. So obstructive, the tension pneumo, the cardiac tamponade; neurogenic, a spinal cord injury; and cardiogenic when there is blunt injury. So cardiogenic might actually get missed at the beginning. So then next slide, please. So as far as airway complications, it's important to realize that kids less than 2 years of age have a more predisposition for hypoxia, and hypoxia leads to cardiac arrest. So there are some differences that we need to talk about. One, they have a increased parasympathetic tone, which means that if you're going to manipulate the airway, chances are you're going to be inducing bradycardia when you do that. And that's the reason why some people recommend, particularly in kids less than 6 months of age, that you're going to intubate to use atropine so that you don't get into that bradycardic episode. These little babies have immature brains that have different responses to trauma. They also have an underdeveloped respiratory center. You give them a small dose of an opioid and they can just stop breathing for a little while. So just be aware that you're going to need to support their breathing. And then there are behavioral responses that will increase the risk for airway complications and respiratory failure. And what are those? Well, little children do not follow commands. They don't understand what you're doing. So they will cry. If they're uncomfortable or they're hungry, they're going to cry. If a baby is not crying when you're stimulating them, that child doesn't have enough perfusion to the brain for whatever reason. And the little algorithm, the little arrow that I developed for you underneath are just of the major differences that you have in children less than 2 years of age compared to older kids and adults. They tend to have a large occiput. So when you're intubating them, you need to make sure that you put a roll under the shoulders to make the airway a lot more visible when you're trying to intubate them. They have small oral openings. They also have large tongues. So that's why we like to use a lot of the straight blades instead of the curved blades to intubate them. Their larynx is high. They have a narrow subglottic stenosis, and they're very easy induced hypoxia with all the different manipulations. Hypoxia leads to bradycardia, and bradycardia, if you don't rescue them from the respiratory standpoint, it's going to lead to a cardiac arrest. Next slide, please. Now, in this particular slide, I just wanted to give you the Glasgow Coma Scale that's been modified for pediatric patients based on age. And you're going to see that the responses are different based on how they do. So a little kid less than a year of age, it's going to respond when you shout to pain. They will respond to pain, or they will have no response to pain. They will not open their eyes when you ask them to open their eyes, right? You're going to have to use pain stimulus to find out if they are actually having a motor response and a verbal response as well. Next slide, please. Now, and this is just the translation for you guys. And then in this slide, I just want to bring some issues about severe abdominal organ injury. it's important for us to actually get the history as always, right? But then the liver, the spleen, and the kidneys are not as well protected in kids less than 5 years of age as they are in the adult population. Their chest is very compliant. Their abdomen tends to be not covered by a strong muscle mass or by fat. So it's very common that they get injured from the liver, spleen, or kidney standpoint. If you have any type of injury, that does not mean that you need to take them immediately to surgery. This is a time where you actually can wait and you can move into the algorithm if the patient is stable or unstable. If your patient is hemodynamically unstable, there's no question that that patient will receive some fluids and blood transfusion. And if there is no response and the hemodynamics continue to be unstable, that's a patient that needs to go to the OR. No questions asked. On the other hand, if you have a patient that has a liver lac or a spleen laceration that's less than grade 4, those patients actually can be watched in the unit. So you keep an eye on the hemoglobin. If the hemoglobin is greater than 7, you get them into the unit and you watch them with hemoglobin levels every 6 hours. And if they do not bleed, if they don't show any instability in their hemodynamics, that's a patient that will not require surgery. And after 48 hours, you can easily say the patient is going to be fine without surgery. If the patient is hemodynamically stable, and we're in the middle of the algorithm right now, and the injury grade is actually high, or if the hemoglobin is less than 7, right there, then you keep going in the algorithm and you can watch them. But if there is any question about the hemodynamics and they start getting hypotensive, that's a patient that needs to go to the OR. On the other hand, if the patient, despite having a grade 5 and having received some blood for a hemoglobin of 7, remains stable in the hemoglobins every 6 hours for 48 hours, in there it says 24 hours, you can actually start thinking about a patient that will not require a surgical approach. So that is a big difference between adult and pediatric surgery approaches. Next slide, please. Now, some common issues about thoracic injuries for patients. For example, thoracic injuries in kids can result from blunt trauma or penetrating trauma. It's the secondary leading cause of traumatic injury and death. The fatality in our pediatric population increases. So normally we have a low fatality rate of 5%. But if you have head injury, an abdominal injury, that mortality increases to 25%. And then complications on the chest, always think about your tension pneumos, open pneumothorax, and massive hemothorax. Next slide, please. As far as some more on thoracic injuries, they're a threat to ventilation, oxygenation, and there are some anatomic physiological factors. One important point is little kids, particularly less than 2 years of age, they have high oxygen consumption. That's why they're so predisposed to hypoxia, and that's why we need to supplement them with oxygen as soon as possible. They also have very small functional residual capacity, unlike the adults where you can hyperventilate and wait a minute to intubate or 30 seconds, depending on who you want to follow. Little kids do not tolerate hypoxia very well. So if you hyperventilate and you intubate, and if you don't get the tube within the first 20 seconds, you need to hyperventilate again because they can actually go down very fast. They also have increased chest wall compliance, and that's a big problem. And that's the reason why the heart and the lungs and the abdominal organs are not very well protected. And the ribs are usually aligned horizontally. They also have weak intercostal muscles, and that's the reason why you see babies using the diaphragm to breathe more often than not. And that's why an abdominal injury can be compromising to the respiratory pattern of a pediatric patient. And the things that you need to look for that can actually increase your mortality: hypotension, a rapid respiratory rate. Any respiratory rate greater than 60 in children, it's bad news. Abnormal chest wall exam, abnormal breath sounds, femur fractures, Glasgow less than 15. All those actually associated with thoracic injury can increase your mortality. Next slide, please. Just a couple of abdominal trauma, I think. So signs of predicting abdominal injury, which patients are worse. We talked about the Glasgow's, the hypotension, the femoral fracture, the elevated liver enzymes when you check them. If the patient has hematuria, that can make you think there's actually a kidney injury, hematocrit or ecchymosis. Now, low injury risk are patients who don't have any abdominal ecchymosis, whose Glasgow is greater than 13, who don't have tenderness or chest wall trauma, who have no pain, they have normal breath sounds, they have no MSs. So all those are reassuring signs when you examine them. If the patient remains hemodynamically stable, and importantly, to continue with frequent assessment. If the patient is hemodynamically unstable, this is the one that you just bypass everything and take them for a laparotomy, because most likely you're going to have a liver that's cut in half or a spleen that's cut in half, and they continue bleeding on some arterial bleed that you're not able to detect immediately. Next slide, please. Just a few words about brain death, and there are some guidelines. This is a website where you actually can get some information. It's the Pediatric Trauma Society, and they have some guidelines for declaring pediatric brain death in our pediatric population. Unlike the adults, sometimes we require 2 brain death exams within a 24-hour period. The definition varies depending on the location here in the United States and with the country at the international level. There are no universal worldwide accepted guidelines, and I'm not sure if you guys have certain guidelines that you follow or if you follow just regular guidelines. Now, ideally, you will have both political and hospital criteria that will help you guide the care for this patient. And I added a couple of references where you actually can get some documents addressing the guideline determination in pediatric patients, brain death determination in pediatric patients. Next slide, please. Just a couple of things about burn injuries. The definitions, you all know what is a superficial one and a full thick one. The full thick ones are the very difficult to manage. The partial thickness can actually become quite complicated. Estimating the surface area is going to be important, and it only includes partial and full thickness. The palms are very important, particularly when you have a lot of scar tissue and you got the same principles that are used in adults apply in children. Now, the big difference between the adult and pediatric patient is how you manage the pain, particularly when you're changing the dressing. Children tend to have a higher level of pain. So all those dressing changes tend to be a lot more traumatic for them compared to the adult. We use a lot of ketamine when we're doing those dressing changes. Rarely we get to the morphine, but that's something to consider. Opioids are something to consider if it is quite a severe burn. Nutritional support for this patient is quite important because we know that there's going to be a lot of there was a lot of anabolic destruction. So you need to get them in a catabolic state so that they can start using more protein for their muscle and skin repair. Next slide. Just a couple of things. How much time do I have? I don't want to spend all your time here, guys. I think I have gone over, right? Claudia?
Yeah, Dr. Arteaga, but we have just a couple of slides left, so we can just finish.
Well, you have the QR in here, and you can actually download the paper that talks about the pediatric population and how to take care of them in a pediatric intensive care unit, how to assess pain, agitation, when and how to use neuromuscular blockade, how to address delirium and the environmental ICU and family engagement, as well as early mobility, which is what makes the difference. Next slide, please. Now, I'm not going to go in detail, but each column addresses pain, sedation, delirium, from the assessment using the tools that we have available all the way down to how you manage them, what is the first line of treatment, and what are some other treatments that you can provide to those patients. Next slide, please. And this one also includes your neuromuscular blockade, and then how to avoid iatrogenic withdrawal syndrome by using high doses or prolonged doses of sedatives and pain control medications, and how to address the ICU environment as well. Next slide. This is my last slide. Thank you for your patience, everyone. So I just want to bring up, there are some references, websites where you can find information. The Open Pediatric is actually, it was developed by a group of hospitals in the East Coast and now has become something national, where there are several videos and several pieces of information, all of them related to pediatric in different areas, from vaccination to critical care to hem-onc emergencies. There are slides, and I just put a slide of the video. There's an interactive video in educating people how to use mechanical ventilation and optimize that. We also have the pediatric fundamental critical care support, top of certain, that teaches about each and every aspect of critical care in different lessons with simulation, and the website is in there. So thank you everyone for your attention, and I hope this has been helpful.
Thank you, everyone. Thank you, everyone, for being here. This is my honor and privilege to be able to present today on burnout and to contribute to this amazing group. Although I have never been in a conflict zone or in a war, to me, being a critical care physician during the first few months of COVID, it felt like a war. However, I definitely recognized that what you have been going through in these last several months have been extremely difficult and nothing compared to what my experience has been. So thank you for letting me join today. Next slide. So we'll be talking about burnout. What is burnout? It's a psychological state that results from prolonged exposure to workplace stress. There are three main dimensions: feelings of energy depletion or emotional exhaustion, increased mental distance from your job, or feeling of negativism or cynicism related to your job, also called depersonalization, and a sense of ineffectiveness or lack of self-accomplishment. Next slide, please. It was first described in the 1970s by Dr. Friedenberger, who was a psychologist and observed the symptoms in himself and his colleagues while working in a free clinic. There is increased attention to this matter in the 80s and 90s, and much more in the last decade, especially with COVID in the last few years, where this problem has been really highlighted. That is extremely prevalent, unfortunately, among physicians across all specialties and among other healthcare professionals. And some of the main drivers for it, it really varies, but the most common ones include excessive workload, inadequate support at work, work-home conflicts, loss of control of one's job or schedule, and diminished meaning and purpose from work. Next, please. So burnout and specialties. There is a work done by Schoenfeld that demonstrated a higher rate of burnout among physicians compared to other healthcare professionals, about 10% more in physicians compared to other professionals. In 2021, Medscape did a survey on different specialties and found out that intensivists reported the highest rates of burnout among all of other 29 specialties. And another study, it's the one in the figure here, has shown that half of ICU physicians and a third of ICU nurses reported severe symptoms. And this study here actually shows that the most common specialties are frontliners like emergency medicine, being anesthesiologists, being also in the first third. And as you can see, that is the one that is like in blue. It highlights that the mean burnout among all physicians participating, and that is really close to 50%, which is truly an absurd number. Next, please. So I want to really emphasize that while burnout manifests in individuals, it originates in systems. So a lot of times we healthcare professionals, when we feel exhausted or with fatigue, moral injury, or any of the symptoms of burnout, we think it's our fault. We think something is wrong with us, and that we are the only ones feeling that way. So I think this is really create awareness is the first step, and knowing that although it is manifesting on us healthcare professionals, it most of the time originates in systems. So here is another example of driving factors in this study, where they studied 12,000 physicians nationwide, also by Medscape, and it showed that the most common drivers are too many bureaucratic tasks, spending too many hours at work, lack of respect from administrators, employers, colleagues, or staff, between others. Next slide, please. So how do we measure burnout? It is important to have an objective measure so that can be studied. And there are different standardized questionnaires that assess symptoms of burnout, but the most common one that has been widely accepted is the Maslach Burnout Inventory, which is the MBI. We'll go over a little bit further on this one. It does include a human services survey that is applicable to healthcare professionals in particular, and it measures three main components, as I already mentioned. Emotional exhaustion, which the higher score of emotional exhaustion, the higher burnout severity. So when you're reading the inventory, depersonalization, also higher score, higher burnout severity, and sense of lack of self-personal achievement is like the lower score, the higher burnout severity. Next, please. So why are we talking about this? Why does it matter? What are the consequences of burnout? So it is extremely common among healthcare professionals, as already mentioned, getting more than 50% of physicians in several studies. And it affects not only a physician's job, but also relationships, mental health, and severely impact their lives or our lives. There is an association, a well-studied between burnout with anxiety, depression, and unfortunately elevated rates of suicide. That compared to the general working population, physicians have a higher rate. And healthcare workers in particular are extremely susceptible with critical care providers being at greater risk. And talking about it affecting physicians' job performance, there is an increased likelihood of medical errors and negative patient outcomes that have been associated with burnout. Next, please. So it is bidirectional. When we are suffering from burnout syndrome, we are going to have more medical errors. That has been shown. And then when you have more medical errors, there is a compounding effect that you have more feelings of negativism and reduced professional self-accomplishment or reduced professional efficacy. So this really can terribly affect our work. Next, please. And our patients, which is really extremely important to mention that burnout is not just about us, physicians, but it will affect our patients. So this is a study published in 2021 that showed that 60% of anesthesiologists reported threshold levels for emotional exhaustion and depersonalization, and 13.8% met the criteria for burnout syndrome. Some of the main risk factors for that were perceived lack of support at work, working more than 40 hours a week, LGBT status, and perceived staff shortages. Next, please. This is a study that was, I collaborated with this incredible team of most of them women physicians, but other professionals as well, that we measured their wellness and how the physicians were coping, those physicians specifically that work in the ICU during the pandemic. So we studied physicians from United States and Canada. Around 430 questionnaires were given, and we have 55% of male and then 45 of female. So we studied, in general, physicians, ICU physicians, and the self-reported moral distress was 57% and self-reported burnout 64%, extremely high. And those who met criteria were about 55%. And also very intriguing is to know that 1 in 5 physicians use at least one maladaptive coping strategy to cope with burnout. Next slide, please. And when they were studying these physicians, they found out 4 different coping profiles. The active or social copers, those were the ones who used venting, emotional support, instrumental support as their strategies. The passive or avoidant copers, those are the ones who used self-distraction, denial, substance use or abuse, and behavioral disengagement, as well as self-blame. The mixed ambivalent copers that have active and passive coping mechanisms. And those, the mixing ones, were the highest rate of burnout. And there are the infrequent copers who are about 30%, and those are the ones who mention very infrequent ways of coping. Those are found more in senior physicians and had the last rate of burnout. Next, please. So I think I want to emphasize the last slide is how a burnout can affect us and how we can deal with that with with unhealthy coping mechanisms that can get us even a worse place. This is a study done in anesthesiologists of the Western Ukraine studying burnout. So they found that anesthesiologists with experience of less than 5 years were the ones who suffer more burnout, about 82%. And the driving factors were working intensity and insufficient salary as the main causes. And this was a study in 2019, so before the conflict. Next. So it's well known that war and urban conflict have been shown to lower the threshold for the development of burnout. And with the surge of civilian and military casualties in Ukraine, ICU clinicians, including anesthesiologists and critical care providers, are overwhelmed and at great risk for developing burnout. The extent, however, of burnout in this population of healthcare providers is currently unknown. And with that, the CERTAIN initiative proposed a project where they were studying the burnout in healthcare professionals. I'm going to pass on to my to Dr. Sarah Zak.
Thank you, Dr. Biehl. As you may know, we launched a survey in September 2022. Our goal was to measure the extent of burnout among Ukrainian critical care providers during the current conflict. Over the next couple of slides, I will present some preliminary results. Next slide. Taking the PICO format, our specific aim was to measure burnout in critical care providers such as anesthesiologists, intensive care specialists, surgeons, emergency medicine personnel, and nursing staff participating in this program. Our intervention was an online survey consisting of the MBI and additional demographic questions. A comparison was made between our cohort and that of the Maslach normative study. A secondary aim of our study is to identify possible interventions that may help increase burnout levels. Next slide, please. In this cross-sectional study, we invited participants via Ukrainian Medical Society's mailing list and our Viber group to complete the survey. Demographic and work-related data and known risk factors were also collected. Our survey was delivered via RedCap. Next slide, please. As instructed by the creators of the MBI, we called it the Wellness Survey to avoid sensitizing participants to burnout. Here you can see the banner we made to promote and distribute it. We provided a link which, when accessed, took participants to our Certain for Ukraine website through which they could access the RedCap questionnaire. Next slide, please. Through this, we were able to measure the amount of times our page was accessed. This is how we determined our response rate. Of the 412 people who entered the webpage, a total of 120 started the survey, of which 97 completed it fully and 23 left it incomplete. Of this number, 111 completed the MBI component, giving us a response rate of 26.9%. Next slide, please. More than half of our cohort was female, 2/3 of whom were married with children, most of whom were not the sole caretaker. More than half lived with their families prior to the war. However, this decreased to 41% during the time of our investigation. 4 out of 5 were attendings working in civilian hospitals far from an active war zone. However, more than half of these individuals had treated casualties from the front lines. Next slide, please. Similar to other studies, most of the respondents were anesthesiologists with an approximate 3-way split between early, mid, and late-stage careers. Next slide, please. When subjectively asked, 2/3 of the participants felt that their clinical practice had been significantly changed due to the ongoing conflict. When asked whether or not there were workplace shortages, nursing staff shortages were implicated the most. Of note, 1/3 experienced shortages of basic utilities such as electricity. Next slide, please. As you can see here, compared to the Maslach normative study, our cohort had increased levels of burnout in the domains of emotional exhaustion and depersonalization, and similar levels of burnout for personal accomplishment. For emotional exhaustion, a level greater than 27 indicates a high level of burnout. For depersonalization, more than or equal to 10 is high. However, 6 to 9 is considered moderate. For personal accomplishment, a value between 34 to 39 is considered moderate. Next slide, please. Thus far, these data show that burnout levels are overall high to moderate across the 3 domains. Further subgroup analyses are underway. Dr. Biehl will now talk about some possible interventions.
Thank you so much, Sarah. So we'll now explore some possible interventions to prevent and to treat burnout. And why is this important? Because you matter, because we matter, because our patients matter. If you're not doing well, it's going to affect our jobs, our lives, our patients. And I found this very interesting that I wanted to mention here. Illness, it's something that has been said. Illness doesn't belong to us. It belongs to them, the patients. Doctors need to be taught to be ill. We need permission to be ill and to acknowledge that we are not superhumans. So this idea that we are superhumans is a cultural value among doctors, which is reinforced by the organization of medical work. It discourages us, doctors, healthcare providers, from seeking and obtaining appropriate help when we are ill. Change is more than do. Next slide. So some of the burnout interventions that you're going to go over here, so pretty much are divided into 4 main categories: organizational level, individual level, team-based, and a combination of individual and organizational interventions. We'll focus more in the individual and team-based here. Next slide, please. So I want to mention that, again, while burnout manifests in individuals, it originates in systems. This I put on purpose again, so for us to remember that there are several systematic reviews and meta-analyses that show that organizational approaches demonstrate greater impact on the burnout. However, what can we individuals do? Small things that we can start doing to decrease the burnout. Next slide, please. So some examples of organizational interventions: promoting a work environment that is safe, that there is a mutual trust between between healthcare providers with different specialties. Solutions involving workflow and technology are also one of the ideas. Providing goal concordant care. So when we physicians are providing a care that is not concordant to our, what we did the oath for in medicine, when we know that we can do more or we are not doing what is the best thing, that generates significant moral injury and burnout. And also the facilities, the organizations can provide confidential support lines. The organizations, several have been providing caregiver support, mental health, anonymous support, which I think is extremely important. Next, please. And this is interesting. I was reviewing the Certain for Ukraine presentations that have been done. This is the first one that was done. And you can see here that Dr. Niven mentioned in one of his slides, care for your patients by caring for yourselves. So we need to take care of ourselves, even in a conflict zone, as all of you are. If we don't take care of ourselves, we are going to get ill, and then much worse consequences will happen. So we'll go over next some of the individual interventions. Next slide, please. So what is well-being for you? It's different for different people. And it can mean physical activity, yoga, meditation, mindfulness, resting, just purely resting, walking outside, seeing the sunrise, seeing the sunset, whatever is valuable to you. But making sure that we understand that self-care is not selfish. We need to understand and practice that we need to take care of ourselves first. It's like the analogy to when we are in a plane and the flight attendant says, if something happens, put the oxygen mask on yourself first, and then you help your children or others around you. So mindfulness and gratitude have also been shown to decrease burnout. And some of the other healthy coping mechanisms are good sleep, good nutrition, journaling, like reflective writing has been also been one of the mechanisms, and really acceptance, meaning accepting that we are not doing well, that something is going, it's not that we are not okay, and it's okay not to be okay. And knowing how common it is, the burnout, we know that we are not alone. And self-compassion, really having grace to ourselves instead of beating ourselves up, it's extremely important. So I always think like, when we have, have a hard day or going through a difficult time, or we feel like we should have done something different, to have grace for ourselves, not to beat ourselves or be harder on ourselves, that doesn't get us any better. And I have seen and, have people mention, and I really have that idea that once, you're talking to yourself, think, how are you going to be talking if was your daughter, your best friend, your sibling, and why you talk with yourself in a much different way. So talk to yourself in a good way. Self-compassion is extremely important. Next, please. So other possible interventions, social support, networking, I think has been extremely helpful for a lot of people to network online with the peers, with people going through similar things, knowing that we're not alone. The 3 good things also, which is at the end of the day, think about 3 good things that happen. We tend to focus on the negative things, but how important is to focus on the good things. Mindset training. And with that, be mindful of your thoughts and your emotions. What you're thinking will drive your emotions, and that's going to drive your actions and your results. And really, a lot of things we can't control, but if you focus on what you can control, it feels easier on us. Next slide, please. So some of the team-based interventions. How can we as a group, as a team, when we are leading with our teams, help to combat burnout? Team debriefings and reflections after having a difficult, a negative outcome, after a patient died, how we can get together as a team and debrief or reflect, allow time for us to process that loss. Structured communication tools is another having, improving our communication skills it's definitely beneficial. And other tools to increase team building, interpersonal skills have also been shown to be beneficial. Next, please. And then here are some of the combined interventions that combine the individual with organization, how organizations can help, but also that has the effort of an individual. And those are, as mentioned already a couple before, communication skills training, peer support groups, coaching programs, and some other programs to manage stress, increase resilience, and so forth. Next, please. And I'm going to mention here a couple of studies that have been done. For example, this is with the group coaching program that shown to reduce burnout in female resident physicians. They studied 100 female resident physicians, and they randomized to being part of a coaching program versus not. And that is a statistically significant reduction in emotional exhaustion compared to the control group. And this is another institution, Cleveland Clinic, that promotes coaching between physicians, and that has been shown to build physician resiliency. Next, please. These are some examples of peer support programs for physicians to mitigate effects of emotional stressors. Mayo Clinic has built this program that's called Compass, colleagues meeting to promote and sustain satisfaction. Groups for physician well-being a few years ago, and has been very successful as well. Next, please. So with that, I want to go over some take-home points, and we'll hopefully have some time for discussion. Burnout is highly prevalent in healthcare professionals, especially ICU physicians, frontliners. Preliminary results of a study showed high prevalence of burnout in Ukrainian ICU healthcare professionals during the existing Ukrainian war. Awareness is really the first step. Awareness of what we are going through. There are several different interventions that can help mitigate burnout, and that can be an individual-based, team-based, and organizational level. Thinking, how can you help yourself, help your team? How can your organization help you? And how can we, as an initiative, help you? Next slide. We have some resources here, great websites for burnout management. We'll try, we can copy and paste this so people have access straight in the link in Viber. Next slide. These are some of these websites. There is a well-being toolkit in Society of Critical Care Medicine. There is some other resources in the National Academy of Medicine. And next page, please. We do have in US, but I want to make sure I put, the suicide hotlines and crisis lines in Ukraine, which are suicide prevention support, one number to call. If you or a close one are having a crisis or suicide ideation. Next, please. There are also other crisis lines in Ukraine, and you can see here some of those. And if you also put those websites down there that I put as reference, they have, of course, in Ukrainian. Next slide, please. This is, I think, Sarah, do you want to go over? And maybe I just going to say thank you very much for this opportunity. I'm looking forward to talking, to discussing with you. And I want to again thank for the certain group and our Ukrainian colleagues.